So, I'd like to welcome you all to today's session titled Mental Health Matters, Anxiety's Role in MCI and Dementia. And for those of you who don't know, my name is Ashton Bateman, and I am a support and education coordinator with the Alzheimer's Society of BC. I'm usually involved in most of our weekly webinars, and it is my pleasure to introduce you to today's guest presenter, Dr. Sherri Hayden. Dr. Sherri Hayden is a clinical neuropsychologist and clinical assistant professor with the Division of Neurology, Department of Medicine at the University of British Columbia. She is also a faculty member of UBC's Women's Health Research Cluster. And over the past 30 years, Dr. Hayden has worked at the UBC Hospital and the Clinic for Alzheimer's Disease and Related Disorders, as well as in her private practice at NeuroHealth. Dr. Hayden's clinical practices serve a variety of populations, including neurodegenerative disorders, traumatic brain injuries, post-chemotherapy cognitive issues, post-COVID cognitive issues, and mental health-related cognitive issues. Dr. Hayden applies preventative and lifestyle medicine principles to her clinical practice. She's also the co-founder of Synaptic Travels and Wellness, providing brain and mental health education to women. Dr. Hayden's chapter on non-pharmacological management symptoms of dementias and their prodromes, chapter 22, is contained within the Handbook of Rehabilitation in Older Adults. And she has authored Women in Mind Workbook, Neuroscience of Mind-Body Medicine for Optimal Cognitive and Mental Health. And you'll find a link to more information on this book in today's helpful resources. So all of this to say, we are in very good hands for today's presentation on the impact of anxiety on cognition. And with that, I am going to stop sharing my screen and pass it over to Dr. Hayden.
Well, thank you for that. I'm very happy to be here to speak to you about anxiety's role in mild cognitive impairment and dementia, and certainly mental health matters. So I'm happy to speak to you about that today. I too would like to acknowledge and express my gratitude for living and working on the traditional unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. So let's get started. So what I thought I'd start with was just a little bit of a review of what I am as a neuropsychologist and what my role is in this area of neurodegenerative disorders and mental health. I'm a neuropsychologist. What that means is that I focus on the study of brain behavior relationships in my practice. And typically, as is the case for most neuropsychologists, that involves administration of neuropsychological assessments. These entail administration of standardized cognitive and mood tests to address the diagnosis and treatment planning for neurocognitive issues and various neurological and psychiatric conditions. At UBC Hospital in the Clinic for Alzheimer's Disease and Related Disorders, the way that we do that is through a full day of testing. So one patient gets a full day of testing. Typically, I'm going to interview the patient. And then after that, I have a technician who spends anywhere between 4 to 6 hours administering tests so that we can get a good map of an individual's brain function and their mental health issues. And from that, we write reports and I discuss the findings with the patients. We typically do that. 50% of our patients we see virtually now. Since COVID, it works better. We serve the whole province of BC. So for those that are located in a more distant locations, we could do that virtually. And for some patients, we need to see them in person. Either it's more comfortable for them or they're just not able to engage in the online practice. So that's kind of a background of what I do, just so you can get some context. And I think it's important to just acknowledge in general that mental health is brain health. And I was pleased to see this study in 2023 that really addressed that and noted to both clinicians and researchers that there is a common genetic, environmental, and lifestyle factors contributing to both psychiatric and neurological disorders. And all of that impacts cognition or function, cognitive function. So I think it's important for us to recognize that. Unfortunately, mental health has a stigma. And you might be surprised to hear that there are many patients that I come across that would rather have a neurological condition, including Alzheimer's disease, than a mental health condition. So I think, really what we need to work towards is reducing that stigma and understanding the role of mental health in these neurological conditions. So that's what we're going to be talking about today. So before we get started, I just wanted to touch on a couple of definitions. So for those of you that may not be as familiar, so when I'm referring to cognition as a neuropsychologist, I'm referring to things such as areas of your thinking. That would include your memory, your attention, your language, visual spatial skills, your ability to understand where things are in space, as well as what we call executive functions. So skills such as planning, judgment, reasoning, really high level functions. When I'm speaking about anxiety in general, we will speak more about specifics, but in general, if I'm referring to anxiety, what I'm speaking about is worry, preoccupation, apprehension, that feels difficult for the person to control and causes a significant distress, or it impedes functional ability. So it affects a person's ability to function in the world. And what we know about anxiety is it's quite prevalent as we get older. In fact, anxiety in aging populations range between 15 and 45% of people over age 65. People who meet anxiety disorders diagnosis range in about the 4 to 15% of people over 65, and an additional 15 to 20% are experiencing what we call subclinical anxiety symptoms. So they have significant anxiety symptoms that may interfere with their daily function, but they don't quite meet the criteria that we have for various anxiety disorders, and we'll touch on those anxiety disorders in a minute. We do know that approximately a third, or around 30% of individuals with some form of anxiety disorder also have cognitive impairment. So these people may also experience trouble with their memory, with their expression, all of that. So that's important to understand as we move through this talk and understanding how that affects our functioning and our thinking. There is a lot of comorbidities, we call this, meaning that as we get older, anxiety can accompany other mental health issues. About 50 to 72% of older adults with depression also have anxiety. Because both ways, anxiety, people with depression for so long can feel quite anxious about that. And people with anxiety also have depression because it can be quite depressing to be anxious on a constant basis. So understand that, that you can have a lot of overlap, which complicates the picture. And what does shift as we get older is really what the triggers are. As many of us are aware, as we age, there are natural changes that happen to our bodies and our brains. And some of that is absolutely out of our control. And so that vulnerability, that can make us feel vulnerable to certain things as we get older. And so what we're seeing in older adults is fear for certain things that may not have impacted them, or they might not have been as fearful for when they were younger. And that might include things like fear of falling, fear of loneliness, obviously fear of illness, fear of cognitive loss, memory loss, fear of impending death or mortality, fear of being dependent on loved ones, and fear of being vulnerable in break-ins or burglaries or assaults. So all of that are triggers that may not be present in a person's life when they're younger. So we have to acknowledge that the triggers that happen as we get older may shift a bit, and we have to be sensitive to that. We also know that the symptoms of anxiety that present in older adults may look a little bit different than they do in younger adults. And specifically, there is a tendency for more focus on somatization, which I'll talk about in a minute. But essentially, what that refers to is a tendency to focus on or have over concern for health issues or the health issues in family members. You might also see anxious older adults report feelings of agitation, panic episodes with racing heart, shakiness, dizziness, etc. There might be an avoidance of trying new things or going out and meeting people, so people are becoming more isolated. Uh, Patients might become more overwhelmed by activities that they would have formerly found relatively easy to accomplish. There's reports of fatigue and difficulty with sleeping. There may be difficulty with decision making or committing to things with others. They may avoid objects or situations that trigger their anxiety. And as I said, there's a focus on health, so there may be a repeated or over focus on checking health indicators. So although, of course, it's important to check our health indicators, if it becomes all consuming. So an example is if you're taking your blood pressure every 15 minutes and it's not medically indicated, that actually may be an indicator that there is some anxiety underlying that behavior. And another, sign or form of anxiety is what we might label shyness or a tendency to not stand up for ourselves or to avoid social contact. All of these can be indicator lights that there is possibly some anxiety in an older adult. In clinic settings, we do know anxiety has great impact on clinical care. Anxious patients tend to have increased use of healthcare resources. They come to the hospital more, they come to clinics more, they go to the doctor more because they're anxious. So we know that impacts clinical care. There's an increased functional and cognitive disability in anxious patients relative to those who don't have anxiety with the same condition. So that increases the need for healthcare resources. And my concern always is the increased possibility of inappropriate use of resources. As I said, we're going to speak about somatization, but as I've mentioned, in older folks, you might see a greater anxiety come out as a greater focus on health issues. And so what can happen is we see patients that might come to, say, my clinic with concern for Alzheimer's disease, and spend quite a bit of time exploring that option when in fact what we're looking at is an anxiety disorder and what they need is more mental health resource. So we need to work on being able to identify these issues more specifically and more efficiently. And it's important to recognize that anxiety is not a single disorder. So when we talk about anxiety, it's not one thing. There are many different presentations, and it's quite important. I tell patients all the time that if they come to me and they say, "Oh, I've been told I have anxiety," I think it's critically important we understand what kind of anxiety, because different treatment protocols are required for different types of anxiety. So generalized anxiety disorder usually refers to those people who have ruminations and worry. It's constant worry. Panic disorder is obvious. There's people who are having the racing heart, the shortness of breath, the panic episodes. Obsessive compulsive disorders are those people that are constantly checking, and that might be checking or excessive cleanliness, that sort of thing, where it's consuming them and they're unable to engage in other activities. Trauma is obviously the source of post-traumatic stress disorder, but even trauma that has occurred years ago can certainly have impact as someone ages, particularly if there's triggers to that trauma in a new environment. Say they get moved to a facility and there's someone that maybe looks like someone that had assaulted them 10 years ago. So it's important to understand a patient's history. Social anxiety disorder obviously is when someone is very uncomfortable in social situations, leading to avoidance and isolation. We all are aware of specific phobias, people who are afraid of heights, people who are afraid of spiders. That can be exacerbated if someone is in a situation where they're exposed to those triggers and they haven't had treatment. Agoraphobia is an excessive phobia, so that would be phobia of leaving the house, of open spaces, of enclosed spaces. So it really is a quite all-encompassing type of phobia. And separation anxiety, although we think of separation anxiety mostly with children, it's important to acknowledge that with particularly with dementia patients, they can experience separation anxiety if they're quite attached to a caregiver. That might be a family member, but it also might be someone in a facility, a specific nurse they become attached to. And you might see anxiety when that caregiver leaves or has to separate for a period of time. So it's important to acknowledge that any of these types of anxiety can be experienced by people as they get older. It's also important to acknowledge that there's a spectrum of degree, right? I'm not going to go into detail here, but just acknowledge that on that spectrum from the mild anxiety, where you might have just some nervousness and unsettledness, but you're still able to function relatively well, to more moderate, where it might be affecting your ability to function a little more, severe, where it becomes much more incapacitating and disabling. And of course, the panic level anxiety, where you're having these episodes of complete and utter panic, where you might have extreme fear, heart palpitations, rapid breathing, you might feel nauseous and dizzy. These tend to be transient, about 10 minutes or so, but certainly disabling. And we need to acknowledge that anxiety fluctuates through our lifespan. And there are sex-based differences in anxiety. Women are essentially, as you can see, about twice as likely to experience anxiety in their lifetime relative to men. On average, anxiety is at its highest in the age groups from around the 20s to around the 60s. Once we hit 75 and older, it kind of levels off and decreases. So it's important to acknowledge that there are fluctuations of anxiety throughout our lifetime. And we need to acknowledge also that anxiety does directly impact brain function. And this is why when I'm doing a neuropsychological assessment, I'm not only mapping out cognition, so we're not only testing your memory and language, different areas of your thinking, we're also doing a comprehensive evaluation of your mood and your personality traits, so I can get a context for that, right? Um, because what we know is that anxiety can increase the development for other mental health disorders. As I've mentioned, depression and anxiety are often highly correlated together in older adults. We also know that anxiety can impact cognitive function. So it can weaken logical thinking and decision making. Often, if you talk to an anxious person, they might describe having difficulty with choosing if there's a lot of options, feeling overwhelmed by that. They might also talk about feeling forgetful, that they have sporadic problems with their memory that is concerning. Um, and of course, there may be changes to emotional regulation. So anxious patients may have trouble with controlling the expression of their feelings. They might cry more easily, get angry more easily, with very little trigger. Or they might, on the other hand, be much more sensitive to perceived threats, much more reactive to anything in the environment. So it's important to recognize that all anxiety can affect all of these things, and all of these things are controlled by your brain. And what we see in our clinic is quite a bit of anxiety. So I thought I'd touch on that. I would estimate about 60 to 70% of the patients that I see in the clinic for Alzheimer's disease and related disorders have some form of anxiety. It may not be of a degree that would meet an anxiety disorder diagnosis, but some form of anxiety. So I thought I would touch on that. And I have seen in the 30 years of my practice there, I have seen, I would say, the amount of anxiety that I'm seeing increase, particularly after COVID, which of course would make sense. But I thought I'd sort of explain to you how I categorize them. These are not diagnoses, these are simply categories, so you can better understand how we kind of tease out what's related to what. When I think of anxiety in the clinic population, what I'm thinking of is it's either reactive anxiety, so that's worry in response to consequences of measurable cognitive deficit. So that would be people who have mild cognitive impairment or dementia. they have problems with their memory or their language or other aspects of their thinking, and they're anxious because they're anticipating problems in function, usually socially, and they worry about that. So they have these deficits and they're worried about how these deficits will affect them in daily life. The primary anxiety, on the other hand, is that the anxiety seems to be causally related to the cognitive deficit. So there is an evidence, if we follow them over time, and we don't see evidence of an emerging dementia, but we see persistent anxiety. It may be that the anxiety is causing their report of memory problems. In some cases, those memory problems might be measurable. But typically, if we look at patients over time, we do neuropsychological assessments over time. My job is really looking for patterns. And typically, patterns for people with mental health issues and cognitive deficits is somewhat different than those who have emerging dementias. So really, that is why we do such intensive assessments. So we spend a whole day with one patient so we can map things out and have a better understanding of what we're looking at. And so obviously the relationship between anxiety and cognition is complicated. As I said, anxiety can lead to and worsen cognitive impairment. So that would be those people that are primary anxiety. It's causing the cognitive impairment. We also know that cognitive impairment, people with mild cognitive impairment or dementia, can have anxiety. So those are the reactive anxious people. All of this is further complicated by people who have coexisting stressors. So in my interview, for every patient I've ever seen, we need to talk about what's going on in your life and what stresses you have, because that can affect how you navigate through any difficulties you're having. And so I thought I'd just explain a little more in detail the interdependent relationship between anxiety, cognition, and function. So if we look at this illustration and you see this sort of vicious circle, and we start at anxiety, you'll see underneath that it says cognitive distortions. That's really just a reference to the tendency for us, when our minds, when we're anxious, to distort our perception of what is happening. A good example is, let's say that I have had a mother with Alzheimer's disease. I'm hitting my 60s now, and I start to lose my keys on occasion. Because I saw my mother progress with Alzheimer's disease, and if I'm an anxious person, the cognitive distortion would be, oh no, I lost my keys for a second time. Oh no, that reminds me of mom. I must have what she had. I probably have Alzheimer's disease. Oh no, I don't want to end up in a nursing home. Oh no, this is not how I want my life to end. So we go from losing my keys once, which could have been just an aberration or just normal aging, to ending up in a nursing home in 30 seconds. Um, and while I'm doing that, if my husband comes along and says to me, you know, we have an event in the afternoon, while I'm trying to look for my keys and I'm, you know, thinking of all these things, what's happening is my thought processes are competing with what he's telling me. So even if I'm looking at him and he feels that I'm paying attention, I'm not really taking that information in because I'm not attending to it. I'm having trouble with attention. That's going to affect our ability to put that information that my husband is telling me into memory. And as a consequence, later in the afternoon, when he comes to me and says, remember, why aren't you getting ready? We're supposed to go to this event. And I might look at him and go, I don't know what you're talking about. You never told me about it. And that, once I realize that I've made an error, will then feed into the anxiety, because I'll go, see, look, I have Alzheimer's disease because I did that. When in fact, it's the anxiety that caused the inattention, which caused the forgetting. So it's a vicious circle, and it's really important that you understand how anxiety can affect cognition and function. So hopefully that helps you. What I also wanted to talk about, as I've mentioned a couple times, is somatization, because it is quite prominent in older adults. In fact, in one 2019 study, 98.8%, astounding, of their depressed participants in the study over the age of 60 had some form of somatization. And as I mentioned, we know that focus on health issues and somatization is very high in anxious populations in older adults as well. So what is somatization or somatoform disorders? Well, it's a collection of psychological conditions where a person experiences body or cognitive symptoms that cannot be accounted for by a medical or neurological diagnosis. So if we're able to rule out a dementia or some other neurological condition, stroke, whatever, but these symptoms persist, then we would wonder about somatization. The symptoms associated with somatoform or somatization disorders is persistent worry. There also tends to be a mistrust and excessive use of healthcare resources. And the co-occurring conditions or the associated conditions tends to be anxiety or depression, and in some cases, substance abuse. So acknowledging that that patients can experience mental health issues like anxiety and depression in physical form through physical symptoms and not recognize them as anxiety or depression is something that occurs quite frequently as we get older, because we are also experiencing changes in our body. And more specifically is functional cognitive disorder, or FCD. This is really when specifically cognitive symptoms, so people are reporting problems with their memory or their language or their executive functions that they find very impairing or distressing, but these symptoms cannot be better explained by a neurological disorder typically, or another medical disorder. And in 2020, there was an excellent study that came out that essentially stated that functional cognitive disorder is likely much more common in clinical practice than we have acknowledged, and is likely underdiagnosed. And their estimates were about a third of patients presenting to dementia clinics may have functional cognitive disorder. And certainly that has been my experience. I think this label itself is relatively new in the field, so it may not always be referred to, but what you need to understand is that it can have a significant impact on a person's function and their perception, and it needs a different type of treatment. It needs a treatment for the underlying issues, which is typically anxiety. You can see in the illustration, it is complicated to make this diagnosis, and that's because it overlaps as far as symptoms with not only subjective cognitive decline. So subjective cognitive decline is essentially just people who are reporting or complaining of cognitive issues. So they're reporting or complaining of memory problems or problems with their language, but it's not measurable. We don't see it on any of the tests. Mild cognitive impairment, we'll touch on that in a bit, and dementia will touch as well. But you can see that there's overlap with the functional cognitive disorder and subjective cognitive decline, as well as mild cognitive impairment and dementia. So it can be very complicated. The way that we take a look at this is, as I said, I'm looking for patterns. I'm looking for patterns in the cognitive performance. I'm also looking for patterns in the mental health assessment. So it's a holistic look at all of that. And I would say, in my experience, this is just my opinion, that all of this is further complicated by some of the advances that we have in clinical care. Although the emergence of biomarker and genetic testing in dementia is quite exciting, it helps, or we're hoping it will help with more specificity and earlier diagnoses. It has led to people seeking diagnoses quite early or before they're even symptomatic. And because there's still uncertainty regarding outcomes of these biomarkers and genetic tests, it can lead to considerable anxiety in some people. And there is a lot of ethical discussion around what is the right approach to this. And we still need to sort some of that out. So let's talk a little bit about anxiety's role in mild cognitive impairment, or MCI, and dementia. I think this illustration really just tells you that it's not a very simple process. It is nuanced and complicated, and you most certainly can't just diagnose it from a scan or a blood test. It takes more in-depth assessment, such as a neuropsychological assessment, to evaluate that. So for those of you that aren't aware, I'm assuming many of you might be aware, but I thought I'd just give you a basic definition of mild cognitive impairment. I am certainly aware that there are different subtypes of MCI that have been presented in the research, et cetera. But in general, if we're talking about mild cognitive impairment or MCI, we're talking about uh, that category between subjective cognitive decline, so those people who are reporting problems with their memory, but it's not measurable, and dementia, right? And mild cognitive impairment are those people who have cognitive concerns, or their family have noticed change, and they have measurable cognitive impairment in one or more domains. So we see that on the testing. It's mild though, so it is not of a degree that affects daily function. So there's some weaknesses, some deficits on the testing, but we're getting reports from the family and the patient that they're functioning relatively well. All right. So that is MCI. Now, we do know that the majority of us, although there are normal changes that happen in our cognition as we age, the majority of us will maintain normal cognition. About 12 to 18% over the age of 60 will have mild cognitive impairment. And the prevalence of mild cognitive impairment does increase with advancing age, which is the same as dementia. Dementia risk increases with advancing age. So for MCI, we know it's around 6 to 7% in the early 60s, and it jumps to 25% in the early 80s, right? About 10 to 15% of MCI people living with MCI will develop dementia with each year, and about a third of MCI due to Alzheimer's disease will meet criteria for Alzheimer's disease in about 5 years. But that means that there's a considerable amount of people that we see with MCI that do not meet criteria for dementia. And that is why it's so important to understand the role of mental health issues like anxiety in this population, because it may be that there's certainly a proportion of MCI patients that have cognitive issues that may be more likely related to mental health factors. And that's certainly been the case in my practice. So let's talk about anxiety and mild cognitive impairment. Well, what we know is that it's clinically and cognitively heterogeneous. So that means that there are vast differences in how individuals present, both their anxiety and in their cognition and their function. So I've had patients who do not have a dementia. They have cognitive deficits that are measurable, but they are so incapacitated by anxiety that they really can't function at all, or barely. And we know that anxiety in later life is correlated with some degree of cognitive impairment. That's been certainly demonstrated in studies throughout throughout the literature. But what we do have is limited research on how this presents and the heterogeneous nature of it. So we need to do more. We need to understand more. Certainly as a clinician, I see a wide spectrum of anxiety disorders in the patients I'm seeing, and it can be very complicated because, as I said, someone who is anxious may have cognitive issues, and someone who has cognitive issues might be anxious. So it really is an art to try to navigate through that. But there are some risk factors that I'm looking for when I'm trying to understand what's going on. Some of that is biological. So some families genetically have histories of anxiety. So it's important to ask those questions, which I would do in every interview. Was someone raised by someone anxious? How long were they anxious? Did they have anxiety in childhood, etc.? Chronic health issues also can raise anxiety and put you at risk for developing an anxiety disorder. And as I said, being female, unfortunately, raises your risk. Not only are we twice as likely as men to have an anxiety disorder, but women over 60 suffer anxiety more than any other age group. So that's a high risk factor. Psychological factors that can raise your risk for anxiety disorders include traits. So if you have traits of perfectionism or traits of obsessiveness, although these are very useful traits, I would say, in performance. So often employers love to have a perfectionist or someone who's a little obsessive because they're going to do the job well. As we age, those characteristics can become a bit problematic in the sense that due to the fact that there's changes with aging that you have no control over, and underlying perfectionism and obsessiveness is the need to control. What happens is those symptoms, those traits then can become exacerbated and result in more anxiety and more behaviors that can be problematic. Obviously, stressful life events that can occur with aging. I mean, as we age, we might experience more losses. Friends, family members may be lost or died, and or we might have more direct experience with dementia. So that certainly is a risk factor, and I do ask patients that if they've ever cared for someone with dementia, if they have a relative with dementia, primarily because it can be a trigger for them. As I said to you before in my example, if I have a family member, if I had a mother with Alzheimer's disease, I might then interpret any behaviors or errors I make as evidence that I have a dementia, despite the fact that that might have only occurred once. So it's important to think of that context as well. And none of this is to say that there aren't patients who have dementia, obviously, with anxiety along with that, but it's just trying to tease out which patients have anxiety that is causing their cognitive issues. And certainly stressors have a big impact on cognition. People who are anxious, depressed, or sleep deprived will score poorer on cognitive testing. That's been demonstrated in the literature. But these weaker scores typically don't predict risk for dementia, but it does support the need for good mental health, and restful sleep obviously as an important factor in your brain health. This cartoon always makes me laugh because I actually did this. I had a very busy week, I'd say probably about 10 years ago, and a lot going on. Very busy in the clinic, and I walk into my technician's office. She's right next to me in the clinic. And I walk in and I'm going like this, and I can't find my phone. And if I don't have my phone, I mean, I was in a panic because I have everything on my phone. I'm very organized in my calendar, etc. And I was panicking. And I was patting myself down, trying to find my phone. She looks over at my hand until I look over and see the phone in my hand. And really, that was just a blip of attention, right? So, because I was overburdened. And so for me, I just took that as an indicator light or a barometer of the amount of stress or, factors that were going on in my life. And I had to take a look at how to reduce that. So just acknowledge that it happens to all of us. Although this talk isn't specifically about dementia, I wanted to just touch on the fact that obviously dementia is the umbrella term. There are many different types of dementia. Alzheimer's disease is the most prevalent type, but we do think that there are different subtypes of Alzheimer's disease. We have vascular dementia, frontal temporal dementia, Lewy body disease, and other types of dementia. So not only is it complicated if anxiety is involved, but dementia itself and diagnoses of dementia is complicated. And it's the pattern of cognition in these different disorders that I'm looking for when I'm looking at assessment, when I'm looking at the neuropsychological assessment. So that with that in mind, let's talk about how anxiety occurs and affects dementia. Well, there are some studies that suggest that anxiety is a risk factor for conversion from MCI to dementia, but this has not been replicated in all studies, so there's a lot of debate still about that. I suspect it's a little bit of both. And certainly, as I've mentioned before, my experience in clinical practice is that a portion of mild cognitive impairment patients are likely having primary anxiety, meaning that the anxiety is causing their cognitive issues, and they will not go on to progress. They will just require treatment for anxiety. So obviously, the assessment and treatment protocols for these different types of groups may differ, and the resources needed may differ. And we really do need to do better at understanding this and approaching it in a more comprehensive way. And I just want to touch on the different reasons why you might see anxiety, or in some cases later on in dementia, the stages of dementia, you might see it expressed in agitation. But some of the reasons there might be anxiety in a dementia patient, someone diagnosed with dementia, whether it be Alzheimer's disease or some other form of dementia, might be because they're tired or in pain. If they're experiencing hallucinations, that can create agitation or anxiety. There can be medication side effects or other neurological side effects. Obviously, someone having cognitive issues can be anxious, as I've mentioned before. It's important to understand history of trauma, just because, as I've said, if you've been placed in a nursing facility and someone looks like someone that traumatized you, it would be helpful to know that in your care. We want to know if there's a history of significant anxiety disorders or close relations with anxiety, as that might impact care as well as any coexisting medical issues might trigger anxiety in dementia patients. And you might see it different, the symptoms present themselves differently in patients with dementia. And as you look through these symptoms, you might wonder to yourself or think to yourself, these symptoms are symptoms of dementia, or could be. So yes, it's very difficult to distinguish, particularly as dementia stages go on, like as we're going to more severe stages of the disease. But what we're looking for is their avoidance of social situations that they might have engaged in before, increased irritability and agitation or restlessness. You'll see maybe sudden onset of wandering or repetitious behavior, muscle tension, not sleeping well. As I said, all of these symptoms may look or mimic just the symptoms of dementia. So the challenge is always distinguishing whether this is related to some underlying anxiety as well. Often it's a matter of treating that anxiety, typically with medication, to see if that has benefit. So I just thought I'd wrap up with, talking about what effective treatments we have available for anxiety, and there are indeed many. For those that have more severe on the spectrum of anxiety that we talked about, for those with more severe conditions, they might require treatment inpatient. But there are many resources, outpatient psychiatry, and some in daycare facilities. That would entail medication through a psychiatrist, or talking therapy through a counselor. That could be one-on-one, it can be in a group or within a family. Obviously, as if we're talking about dementia patients, that would be most effective for people with MCI or early stage dementia. As we start to progress through more severe stages of dementia, engaging in talking therapy can just typically agitate a patient and will not be helpful to them. And they may not be able to apply what they would learn in therapy to make changes that would be a benefit to them. So that's why often as we head into the mid and later stages of dementia, there's a reliance more on medication to manage anxiety. For the milder stages, there's also some amazing free resources through Anxiety Canada that I'd encourage you to look at. One of them is this app that gives you a number of very useful CBT, that's cognitive behavioral therapy tools to navigate through any sort of anxiety or worry you might have. And these are very useful teaching tools to help you if you're experiencing anxiety yourself. And a passion area of mine as a yogi of 40 years is also, I do many talks on the importance of mind-body practices in managing any number of symptoms. We do know there's strong evidence in the literature of yoga and meditation practice and how it's associated with mild to moderate improvements in cognitive function. The areas that had the strongest effect, the strongest impact by these practices were the areas of attention, processing speed, memory, and executive function. Obviously, these practices are also of benefit for anxiety. If you're interested in that, you should take a look at, there's a very prolific researcher. Her name is Dr. Sarah Lazar in Harvard, at Harvard University. She has a website and you can see all the literature, all the research that she's done focused on that area. So it really is quite an interesting area, and it's an easy practice to incorporate into your daily life. There are many different types of yoga. There are many different types of meditation. Even just breath work can have a great impact. So I thought I would end here and be happy to take any questions or, discuss anything that we've talked about today.
Thank you so much, Dr. Hayden. What wonderful information. We've had a really good turnout today, and I definitely have some questions that have popped up kind of throughout the presentation. So one of them is just about UBC. So someone asked, how does someone get a referral to UBC for an in-person neuropsych assessment or evaluation?
Yeah, so the Clinic for Alzheimer's Disease and Related Disorders is at UBC Hospital. We serve the whole province of BC, so your location doesn't matter. But it does require medical referral. So you need a family physician or a physician to refer you. It could be a specialist if you have a neurologist, but it also can be a GP, and they would need to make the referral. Then typically there's about 6-ish neurologists in that clinic and one of me for the province. So that means I don't see everyone. We choose, and I can only see certain people. I tend to see people with comorbid mental health issues, like the complicated ones or the very early ones. People that are maybe a little further along in the disease process, I would be less likely to see.
Thank you. Yeah, and someone had a similar question, I think kind of more along the lines of your clinic, like the neurohealth clinic. They were also wondering, is a doctor's referral required?
It's not required for that. You can just, there's contact information on the website and you can contact. I would say that you need to know that it's not covered though, unfortunately, by MSP. So there's a cost associated to those assessments. Obviously the assessments I do in the clinic are covered, so you don't have to pay for those. And I always encourage people to go there first because I don't really want you to pay, but unfortunately, that's our system.
Yeah, thank you for clearing that up. Um, Someone had asked what the association with double-digit concussions in a person and MCI. So with concussions, do we see that MCI progresses?
Well, we do know that repeated concussions can raise risk. It is a risk factor for dementia. It's a small risk factor, and it
Mhm.
really causality is difficult to distinguish. In some patients that I've seen that have had multiple concussions, they don't have a progressive disease, and in some they do. So, I think it's a very complicated formula of genetics, medical history, other issues, environmental issues. But one of the most exciting things that has come out of in my years of practice has been the studies that are now telling us that a large amount of dementia cases worldwide are likely associated with lifestyle. So I always tell people lifestyle is probably the most significant factor. There was a study in 2020 that came out in Lancet, which is a very well-respected medical journal, about a worldwide dementia risk. It was the Dementia Commission, Risk Commission, and they found 40% of dementia cases worldwide are likely related to lifestyle or modifiable changes. So we could do more. We can do some things to prevent, even if you've had history of head injuries.
Right. Yeah, thank you. Yeah, we talk a lot about, protective factors
Yeah.
with when we talk to our clients. So yeah, that's a great statistic to share. Thank you. Someone also had a question about perimenopause and if that is related at all to MCI.
Yeah, so I'm a menopausal woman, and that is an area of passion of mine. As you've mentioned, I've written a book and I do talks on women's brain health. We do know, unfortunately, that it does raise risk as we go through perimenopause and beyond. In fact, what we know about estrogen, some of that is limited because the studies on women's brain health and even animal studies were not required to be included until 1993-ish, which means we don't have enough. But there are a lot of women researchers and a lot of researchers working on this. What we do know is that estrogen is protective, likely, that women with longer periods or exposure to estrogen, so women that started their period early or have menopause later, tend to have a lower risk for Alzheimer's disease. Unfortunately, women are 2/3 of Alzheimer's patients are women. And it's not because they're living longer. We think that it has something to do with estrogen. So what we do know is that women who are, I think it's within 5 years, who take estrogen, so that could be birth control, whatever, depending on your health history, your reproductive health history, may reduce risk. I always recommend a book called The XX Brain. I didn't put that in that other one because I didn't know that this was going to be the focus, but it's an easy book to look up. It's on Amazon. It's called The XX Brain by Lisa Mosconi, and she goes through all of that. And I recommend anyone who has questions about menopause or perimenopause and its impact on cognition should read that book.
Thank you so much. Someone had asked about strokes. So if a patient has had one or more strokes, can that increase their risk of dementia?
I wouldn't say that I mean, assuming that it's not a progressive vascular dementia, if they've had, isolated strokes, even a couple of them, a few of them, I don't know that it raises the risk for dementia, but obviously it will impact cognition, depending on the location of the stroke. And so it will impact function. And that, with aging superimposed, could make it look like they're worsening more than they normally would. But that's why we would measure it and monitor it over time.
Thank you. This is a question about treatment. So Doug asks, any thoughts on the usefulness of transcranial magnetic stimulation in treating anxiety and MCI?
Yeah, I mean, I'm not super familiar with that. There is a researcher in at UBC who I think is doing that. Um, and I have great respect for him. So I don't really have opinion. I think if you have an opportunity to get into a research project that involves that, I encourage it. I've had a patient who had, it was depression he had, but he went into a study with that and I think it may have helped him. I think there's still a lot of data that's needed to understand it.
Fair enough. Thank you for that. And then I've got just one last question here. I think now things are slowing down a little bit. Thank you everyone for just these wonderful questions. Someone asked, my mom got a referral to a geriatrician and arrangement to do a CT scan after having a MOCA done. Is that the appropriate route that we should follow in the meantime, or any further actions that we should take for this assessment?
That's a perfect route, right? We get to see people in our clinic. We tend to see the very complicated cases. So a geriatrician might refer your mom to us if they can't figure it out. But geriatricians are excellent. They're going to look at you as a whole person. They're some of my favorite clinicians. So yeah, that's perfect. It's exactly what you should do.
Thank you. Yeah, no, we love to hear that if everything is kind of happening in a good sequence like that, right? So thank you. So I hope you all enjoyed the presentation today, and I just want to thank our guest presenter again, Dr. Sherri Hayden, for such a wonderful presentation and for answering all the questions. So thank you again, Dr. Hayden, and thank you everyone for joining us today for the webinar, and we hope to see you again at another one of our webinars. Take good care.